Okay, so LASIK, I did like 5,000 LASIKs. I had this eye LASIK like 20 years ago when I was at Harvard. I stopped because I got like dry eyes and night glare, and some people are going to get dry eyes and night glare. Almost everybody gets a little bit. Now, it's impossible to determine how much people are going to get because we were trying to...
What happens if your eyes are already dry?
You're screwed, okay? In other words, LASIK is...
So is it a bad thing to get LASIK if you have dry eyes naturally?
Yes. Okay, I'm just telling you, okay? LASIK is always going to make your eyes slightly drier because you cut the corneal nerves. In other words, the corneal nerves, if you know the diagram, it's like, okay, the corneal nerves, which are on the back of something. If this is your eyeball, right, and here's your cornea, all the corneal nerves are coming in like this. 90% of them are coming in from the sides, and only like 10% are coming in like that. It's just the anatomy of the eye, okay? So, unfortunately, we used to cut the corneal flap like this. It's sideways, okay? It used to be called like nasal flap, temporal hinge, something like that. We're coming with the thing this way, okay? And the reason we did that is because it's easier to access when you're cutting in that direction. You just have more room cutting in that direction where the thing goes, okay? But then the problem is, because I've been doing this for 30 years, okay? So that was like 30 years ago. And then we stopped doing that because we used to get like elevator syndrome. It's like the patient would seem fine when you just checked them 10 minutes after the surgery. They go down on the elevator and they'd call you on a saddle and say, oh, my eye's vision just went bad. And then they come back up and you'd see the flap would slip, okay? Because the flap, if you think about it, when the flap had a hinge that looked like this, you know, the lid would be blinking like that. And there's nothing, people don't know, LASIK, there's nothing holding the flap there. It's just sitting there, okay? It gets sucked up by osmotic pressure, but it's just sitting there, okay? So when they blink, 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 a lot of times you get flap slippage. Not a lot, like 10%, but who the hell wants 10% of their patients coming back and slipping, okay? So then about 25 years ago, we switched to superior hinge, okay? So now we're cutting the hinges like this, because when you cut it like this, okay? Then when the person is blinking, the lid is actually putting the flap back into place. You see what I'm saying? So the reason we switched from, this is like nasal temporal thing, to superior is because you get rid of elevator syndrome, okay? But unfortunately, we fixed one problem, we caused another one, because now we screwed like 90% of the nerves. Because when we were cutting like that, you have the nerves coming here. It's not as dry. See what I'm saying? We just screwed the nerves, okay? So how does the cutting the nerves screw the dryness? There's no clock mechanism in your brain that causes your eye to blink. It's the subconscious sensation of dryness. So you know that because if you really stare for a long time, you can't help it, okay? But it's conscious, okay? So when you're killing 90% of the nerves and you only have like 30%, 10, 20% of the nerves left, you're relatively anesthetic. You just don't know that you're dry, okay? So we've done some studies where we take patients before LASIK and measure the blink rate, and it's about once every 5 to 10 seconds is a normal blink rate. And then we do it after LASIK with the cutting and kill the nerves. It's like 10 to 15 seconds. You're essentially staring your eyes dry and you don't realize it because you don't feel it dry because you're missing your nerves, right? And the nerves never grow back because once you cut the nerves, you're screwed. Like once you're paralyzed, you don't get up and walk. Nerves cannot regenerate, okay? So...
Could you train yourself to blink more often?
Hey, it's a good question, okay? I told you she was smart, okay? So this is like 20 years ago when I was doing LASIKs. Like many surgeons, I would say to the patients, try to blink more often. It's so stupid. You're blinking like 1,000,000 times a day. You can't just be like, I will blink. It's impossible. I used to say that. I was guilty of saying that, but it's bullshit. You just can't do it, okay? So everybody who has LASIK has got a little bit more dry eyes. The reason that not everybody says that is like she said, she's smart. Some people have a lot of reserve and they're nowhere near dry, okay? So if you're like nowhere near dry and you get a little bit dry, you're still asymptomatic. You wouldn't figure it out. But like she said, if you're already on the cusp and you're like, you know, sometimes my eyes feel dry and sometimes I put into you really shouldn't get LASIK because you're going to be drier, okay? And again, if we had a really good way to test how much drier people would be, that would be one of the pre-op tests that we would do. And then people who are going to be dry after LASIK, we wouldn't do that. We'd switch to the surface. But we don't have that test. There's no way to do it, okay? And then the other thing is, part and parcel of the LASIK procedure, you're going to wind up with a two-piece cornea. right? Because I'm going to take this flap, I'm going to cut it, I'm going to put it back down, and you're going to flap the rest of your life, okay? So number one, if you do any contact sports like kickboxing, martial arts, you really, it's almost malpractice to do LASIK, because if the guy gets punched in the eye, the flap gets torn off, and he won't see well for the rest of his life. We don't have artificial cornea, okay? So what is the chance of that? Well, it's not that low if you're a kickboxer, okay? But the chance of that happening if you had a surface ablation and flap is zero, you know what I'm saying? So when you have a two-piece cornea for the rest of your life and the light comes through, you're going to have some backscatter off the interface. Let me just borrow your glasses for a second. Okay, so let's say I go to lens crafters and they do, they grind the lens, and now I come back, it's like, I try it, it's not perfect. I go back, oh, it's not perfect. They measure, oh, I'm sorry, we're going to regrind your glasses. What they do, you'll hear them go, they have a computerized lathe and just go, they're really reshaping the lens. You hear them do that. It's like, and then give it back to you like, oh, that's fine, it's fine, okay? Now, what if they did a LASIK instead, right? This is what they do. They'd take a blade, they'd cut this lens in half, right? Then they take the top piece, they just set it aside. Then they take the bottom piece, they go sand it down. Okay, then the top piece, they stick it back, they glue it back, they hand it back to you, right? You put it on, you're like, you know, it's better, but at night it's really kind of weird. Like there's some glare, you know why? Because you got a two-piece lens. Who the hell would want that, right? Okay, so optically, a surface ablation where you're just polishing the surface is always going to be better than cutting this thing and putting this thing back. Always. Obviously, the only advantage of the whole LASIK thing is quicker healing. That's the only advantage. Everything else is a disadvantage. It's not as safe. You can punch the eye, screwed. You're going to have dry eyes a little bit, right? And you're going to have night glare. So everybody who chooses our procedure, and we have a higher price point and we have more educated customers, I guess, because it's a higher price point, they're purposely choosing a procedure that's slower and more expensive. I mean, your kid's a little different because you have good health insurance, so we can get money from that. We're the only side that takes health insurance, so it's going to be cheaper. But anyway, if you don't have health insurance, it's going to be more expensive, longer recovery. I'm the only surgeon in the country that got LASIK in one eye and LASIK on this side. Okay, so I got this one 20 years ago. This one I did 2 years ago myself because it's so safe. I was going to show the world I could do it myself. So this eye has some dry eyes and night glare. This side I don't. Okay, but this side took 1 or 2 days to recover, and this side took 3 or 4 days, maybe 5. Okay, so to be honest, I'm not going to lie to you, it's going to take twice as long to recover. But your chance of getting dry eyes and night glare are vastly lower. If you get punched in the eye, the flap can't come up. And it's, I think, a better procedure. And I was doing both procedures for like 10 years. So from like 30 years ago to 20 years ago, I was doing both procedures, giving them a choice, different prices, whatever. Then I had a patient like in your chair. This is a very smart, like investment banker kind of guy, okay? And he said to me, hey, do you honestly think in your heart of hearts, swear on the Holy Bible, that your surface procedure is safer than cutting a flap for me? I said, yes, I can't tell you otherwise. It's safer. He's like, didn't you say there's so many guys around the city who are cutting flaps? I'm like, yeah, and they're all cutting flaps. He said, if it's safer, and if you really think it's safer, why go with this two thing? Just do the one thing, and all these people want a quicker procedure and don't care so much about the safety and the dries and that, go somewhere else. And I was like, you know, that kind of does make sense ethically, and it kind of does make sense in branding, because we could just brand ourselves as the only non-cutting center in the country, by the way. So that's what we did like 15 years ago, and that's how we switched. So let me get back to the diagram, okay? So,
I have a question. So,
well, let me just finish the diagram and then ask a question, okay? So then we cut a flap, okay? So cut a flap. That's the flap, okay? So this flap is typically about 150 microns, okay? That's about it, okay? So once you cut that flap, obviously you have 400 microns left, right? 400 microns. And then your high prescription is like -9, okay? So -9 plus some astigmatism really makes it -10. That's the spherical equivalent, okay? So our laser is very efficient. We could put our laser in like tissue sparing mode. It's only taking off like 10 microns per diopter. But I'm telling you, most lasers are taking off about 20 microns per diopter, okay? So if you do this times 20, right? Then you're going to laser off. This is getting vaporized. You're kind of screwed, okay? Because you're going to be left with, let's say, 200, maybe 250, right at the limit. That's your flap. You see what I'm saying? Because they just vaporized 200 microns or maybe 150 microns, if you're lucky, to get rid of your -9. That's why you're right at the cusp for LASIK, and I really think that TLC is a little negligent, not telling you right at the cusp. You know what I'm saying? So now look at LASEK, okay? So it's the same situation. There's no flat, right? So I may be like, right? And I just told you, our laser is more efficient. Ours is only taking off 10 microns per diopter, okay? But even if it were taking 20 microns off, I'll do the 10 and I'll do the 20. In reality, it's 10, and this will be 20, right? So in reality, because our laser is so efficient, I just lasered off 10 microns per diopter at minus 10. That's like 100 microns, right? It's gone. What do you left? 450. Are we anywhere close to 250? No. We can laser you 25 pounds if we want to. Okay? Even if on their laser, which is we got a VISX, they got an Alcon. The Alcon takes off twice as much tissue. Even if they did their laser and took off the 200 microns, you could see you would still have 350 microns. You see what I'm saying? You're not near the 250. So that's why we don't even check thickness on -3s or whatever. We're never going to get there. The only reason we check thickness on you is you're -9, and also you said that you're thin cornea. I want to reassure you, okay? But we don't have to check thickness because how the hell are we going to get to the 250? You know what I'm saying? That's why I did the highest prescription in the world. I did -22. -22, the girl came in from China. She was like 650 microns to start with, so we had a lot of tissue to work with, okay? Now, the other thing is we're going to talk about like we're going to talk about this ICL situation, because that's your other option, okay? And we do have a little diagram, Constantine, that you can kind of remind yourself and Sean to use, because I don't think you guys can memorize this stuff. I think none of them memorize this. Anyway, this is like a little diagram between ICL, SMILE, whatever, okay? So your other option is ICL, which is like a misnomer. They call it intraocular contact lens because it sounds nice. It sounds like contact lens, but it's not an intraocular contact lens. You'll see why, okay? So this is the diagram of your eye, and it's going to go in this potential space that's really small, okay? So I'll show you. Okay, so this is a better eye diagram. So ICL, what they have to do is they have to stick a lens that's really a potential space. It's supposed to be going in the potential space between your iris and your lens. This is a lens, okay, of your eye. You can see, look, it's kind of to scale. You can see there's a lot of room in between the cornea and the iris, right? There's no room here. It's a potential space. There's not supposed to be anything there. It's like a millimeter, okay? So the problem is when we stick, and I've done this before, when you stick the lens in there, if you hit the lens, the real lens, this becomes a cataract. You have to take this out. It's another operation, and you won't be able to read because once they take this lens out, they don't have ones that move or gel ones. They just have plastic ones, and you'll be like 70 years old because you will just not be able to read. Sometimes the lens starts chafing against the iris because the iris is not static. And obviously when the pupil dilates and constricts and light and dark is doing that 100 times a day. So sometimes if you get a little bit of chafing against the back of the iris and this little fake lens that you're going to put in there potential space, you call it bleeding. Sometimes you have something called UGG syndrome. And then you can have glaucoma because sometimes the blood and the pigment goes into the direct or meshwork where the drain of your eye, and then you get glaucoma. So sometimes you have to explant the lens, take it out, and then sometimes when it chafes, guys don't care so much, but girls care about this. Sometimes you wind up with a permanent defect of your iris. It's called like a moth-eating appearance. It looks like a moth just took bites out of it because the lens keeps chafing, rubs off the brown part, and then you've got this weird-looking iris. Okay, so the ICL thing, I like doing that as a last resort for like much higher prescriptions, like -20 or something like that. Okay. It's more expensive. They probably quoted you more expensive price. And I really think the disadvantage primarily is it's more dangerous because if you have an infection inside your eye, you could go blind. If you have an infection on the surface, you can't go blind because it's not in your eye. And even if you have a bacteria that's resistant to every kind of antibiotic, I could just pour like betadine or iodine on your eye and just kill everything. I'd use a sterilizing instrument, not a antibiotic. And you can't put betadine or alcohol in your eye while you'll be blind. Okay, so that's why I don't think you should get ICL. How much did they quote you for ICL?
It's like 10 grand.
Yeah, it's always like 10 or more, 10 to 15. Oh, you forgot to do that with me.
I did it.
Oh, you did it?
I updated it.
Oh, good. So like a couple of weeks ago, we had somebody with ICL, and she's gonna do this here anyway. And then our quote came up so much lower, and I think our procedure is like better. So I told Nana just to increase the price for the higher prescriptions because I don't know why should we be doing these prescriptions so much cheaper than ICL because I think it's a better procedure. You remember that girl's name?
I think it was a man.
I think it's Zoe, isn't it?
Mm-hmm.
Yeah.
Is she gonna? Did she deposit yet or something? Just try to follow up with Ben because he'll leave in a few days. He'll know. You had some more questions?
Is the main reason why LASEK is less dry than LASIK that
You're not cutting the nerve.
you're not cutting the nerve, and the
Yeah.
nerve is what's causing a person to blink, and that's.
And also, there's another fact I wasn't going to get into too much, but there's certain
I think those are also my papers.
there's certain agents that are getting secreted by the nerves that cause tear production. Okay, that's another factor. So by the time you get the nerves cut and screw the blink rate, you're also not getting these factors that get secreted off of the nerve endings. That's the other reason.
And then my other question is, if LASIK is so much better, then why are there so many more LASIK surgeons?
It's a very good question. It's a quick recovery and it winds up with a quicker. It's more efficient throughput for the practice. Now, we're doctors, we're not supposed to think of patients as little boxes in an assembly line, but I'm telling you it's much more efficient. Because when I was doing LASIK, I would see the patient pre-op, op, post-op, it. Okay, so I'd see them 1 pre-op, op, and then like a 1 week post-op sayonara. For your prescription, because you're -9 or something, we're going to have to see you 1 week, 1 month, 2 months, maybe a 3 month, maybe not. So you're saying 3 to 4 post-ops instead of 1. It's not efficient for the office. So you can make much more money on LASIK, by the way. I think that's the main reason. And the second reason is the patients want a quick recovery. So about 10 years ago, I did a CME lecture at Harvard because I went to Harvard. It was for general ophthalmologists. They had like specialists in cornea refractive, glaucoma, retina, whatever, okay? And then I did the one on refractive, obviously. And there were like 95 ophthalmologists in the audience. So it was really convenient because almost 100, right? So I said to them, okay, with a show of hands, if you had to get some kind of laser vision correction and someone held a gun to your head, what would they do? It was like 80 surface ablation, LASEK or PRK, which is an older painful form, 20% LASIK, okay? Same audience, right? I said, okay, how many of you guys are doing LASIK, okay? It's like maybe 50 people raising their hands. Okay, how many of you guys are doing surface ablation? It's like 1, okay? So I said, why is that? You just said if it was you or a family member, you would just do a surface ablation and one of those flap crap. But why are you doing it different with your patients? And there's a guy in the audience, he's like, look, quite frankly, the amount of time we spend counseling them and trying to push them to the safer procedure takes so much time, it's not worth it. You don't get paid for it. Just let them make their own decision. If they want a quicker procedure, quicker recovery, more risk, that's it. The market's deciding. So that's basically the reason.
I know I'm on the high end of prescriptions, but for people with lower prescription, the risk is probably just less.
Not the risk for dry eyes, and not the risk for night glare, and not the risk for trauma. The only risk that's smaller is the risk for ectasia and a corneal transplant. You see what I'm saying? So Ben was a -3. He did a LASEK. He was back to work in 3 days. He was 2015 in like 7 days. And you know what I'm saying? He's going to be good for the rest of his life because I'm over lasering him. He's only 23. If he went to any other center in New York, they would just put in his prescription. He would progress another diopter. He wouldn't be -350 when he's done. He'd be -1.
There's no drawbacks of over lasering?
You could talk to Ben. In other words, I over laser him by like 0.75. I'm only going to over laser you by 0.25. He can't detect that. You just can't. If it's on the cornea, you just can't detect it.
But my question is, there's no what are the drawbacks of doing that?
There are no drawbacks of doing that.
Overcorrecting?
If he doesn't perceive it, how could there be a drawback? The only thing is, if I didn't over laser Ben by 0.75 -0.75 age 23, he's going to progress another diopter, right? So he's going to med school next year, MD, PhD, a lot of near work. So instead of being -250 at the end, I think it was -3, okay? So instead of being -3 to 0, he would have gone to -4. Just because we laser him doesn't stop his growth process, doesn't stop his aging, okay? So he's going to he would have gone to -1 if he went to another center, okay? So at age 30, instead of being -4, he'd be -1. He's better off. -1 isn't 2020. -1's not even legal to drive. -1's probably 2060. And then he would say to his friends, how'd it go, Ben? Well, I did it 7 years ago. It's pretty good, but it kind of wore off.
So you would have to get it recorrected.
He'd have to get recorrected. But this is why people think it doesn't last. It's just because the doctors take the young patients, they over laser. Ben would tell his friends if he wasn't working here, I got it done 7 years ago. It was pretty good in 2020 in the beginning. Kind of wore off. Now I'm kind of about 20 60. I'm still glad I did it, but I'm just telling you it's not as good as it was. They think it wore off. It didn't wear off. He just went to a doctor, didn't over laser him.
Wearing off is essentially your eye growing and then
Axial elongation. I wouldn't say wearing off. The misnomer where the public thinks it wears off 99% of the time is going to a surgeon who's not overcorrecting the younger myopes. That's what it is.